Welcome to section 4 of embryology. In this section, we'll be discussing left to right shunts. Let's get started. Left to right shunts occur when blood from the systemic arterial circulation mixes with the systemic venous blood. These include conditions like ventricular septal defects, atrial septal defects, and patent ductus arteriosus. A key distinction between left to right shunts and right to left shunts is that newborns are acyanotic, but cyanosis can present many years later. This is because a left to right shunt results in oxygenated blood going back to the deoxygenated side of the heart. Therefore, deoxygenated blood is not entering the systemic circulation, at least not initially. Over time, however, left to right shunts may reverse, and this process of shunt reversal is known as Eisenmenger syndrome and is a potential complication of left to right shunts. Let's talk about this in a bit more detail, and then we'll go through the 3 left to right shunts. So here we have 2 drawings of the heart. The left image will represent early in the course of a left to right shunt, and the right image will represent what will happen later on, so early and late. Let's say this patient was born with an atrial septal defect, or ASD, which we can see right here. The pressures on the left side of the heart are normally much greater than the right side of the heart. This is because the left side of the heart must pump against the entire resistance of the systemic vasculature, whereas the right side of the heart only has to pump against the resistance of the pulmonary vasculature. So the blood flows the path of least resistance. And in this patient with an ASD, the blood goes from the left atrium to the right atrium. So now we'll focus our attention on the image on the right, which represents late. The excess blood on the right side of the heart can enter the pulmonary circulation, and the fluid overload in the pulmonary vasculature can cause arterial remodeling and increased pulmonary vascular resistance, so increased resistance. Because the right ventricle now has to pump against more resistance, the pressure on the right side of the heart increases, and the right ventricle attempts to adapt via hypertrophy. Eventually, the pressure on the right side of the heart becomes greater than the left side of the heart, which can lead to reversal of the shunt, and then a patient will develop a right to left shunt. So the pressure over here is less than the right side of the heart, and we get blood flowing from the right atrium into the left atrium. This is problematic because now we have deoxygenated blood going from the right side of the heart directly to the left side of the heart and then into the tissues. So again, Eisenmenger syndrome occurs when a chronic left to right shunt goes uncorrected. This results in increased pulmonary blood flow, increased pulmonary vascular resistance, increased right ventricular pressure, along with right ventricular hypertrophy, and eventually reversal of the shunt. This leads to cyanosis, digital clubbing, and polycythemia, which are all complications of hypoxia. The time course varies, so patients in various age groups may present with Eisenmenger syndrome. All right, now that you understand Eisenmenger syndrome, let's discuss the 3 left to right shunts. Let's first talk about ventricular septal defects. Ventricular septal defects, or VSDs, are the second most common congenital heart defects. A bicuspid aortic valve is the only other congenital heart lesion that is more common. These are often asymptomatic at birth and close spontaneously. However, if the lesion is large enough, then it will rarely close and can create some major problems after birth, such as Eisenmenger syndrome and heart failure. A VSD may present with a holosystolic murmur, depending on the size, and because this is a left to right shunt, there will be an increase in O2 saturation on the right side of the heart. Finally, VSDs are associated with infants of diabetic mothers, fetal alcohol syndrome, and Down syndrome. All right, let's pull up an image and talk about the physiology in a bit more detail. Here's an image of a ventricular septal defect. You can see blood flowing from the left ventricle into the right ventricle. Just like we discussed a second ago, blood flows this way because the left ventricle must contract against the entire systemic vascular resistance, whereas the right ventricle must only pump against the pulmonary vascular resistance. Therefore, blood naturally flows to the path of least resistance and goes from the left ventricle to the right ventricle. Like I mentioned on the last slide, if the defect is large enough, then a lot of blood will flood the pulmonary vasculature and can cause Eisenmenger syndrome, as well as heart failure. All right, that's all for VSDs. Now let's move on to discuss atrial septal defects. Atrial septal defects account for about 10 to 15% of congenital heart diseases. They're classified by their anatomic location and result in communication between the right and left atria. Primum ASDs develop when the septum primum does not fuse with the endocardial cushion. Additionally, they occur with other congenital anomalies, such as atrioventricular canal defects and VSDs. Secundum defects occur due to arrested growth of the second septum and result in an opening in the fossa ovalis. These defects are much more common than primum ASDs and are an isolated finding, meaning that they don't typically occur with other anomalies. Let's look at a picture of this so you can see what I'm talking about. Here we can see a right septal view and a frontal view of the left atrium and right atrium of a normal heart, a primum ASD, and a secundum ASD. Notice that the septum primum normally fuses with the endocardial cushion to form a portion of the interatrial septum. If fusion with the endocardial cushion fails, then the patient ends up with a defect near the endocardial cushion, and this is known as a primum atrial septal defect. So in this case, we can see the blood flowing from the left atrium to the right atrium near the endocardial cushion right here. If we look at it from the right septal view, we can see that this lesion is approximately right here. Also notice that the septum secundum, right here, which you can see in green, grows near the septum primum and helps cover up the septum primum. However, if the growth of the septum secundum is arrested, then there's a large defect towards the top of the atria, which you can see right here. And this is known as a secundum atrial septal defect. As you can see, this looks very similar to a patent foramen ovale, or PFO. And if we look at the right septal view, we can see that this occurs in the exact same location, right here. However, an ASD is different from a PFO because tissue is lacking. In a PFO, all of the tissue is present, the interatrial septum just hasn't fully closed after birth. Atrial septal defects result in closure delays of the pulmonic valve because more blood is on the right side of the heart. This means that the right ventricle must pump more blood through the pulmonic valve, so it takes a little longer for everything to pass through and for the valve to fully close. Patients also present with a systolic ejection murmur and a fixed split of the S2. The physiology here is a bit complicated, and we discuss these findings more in our heart sounds physiology section, so I'm not going to discuss this again. The heart failure occurs with time as excess volume overwhelms the right side of the heart. Patients may also develop paradoxical emboli, which are venous emboli that can travel through the ASD and become arterial emboli. So for example, if a patient has a DVT and then has a stroke, you should be concerned about a septal defect, such as an ASD that allowed the embolus to go from the leg to the heart and then to the brain. This is very abnormal because a DVT would be expected to go from the leg to the heart to the lungs and cause a pulmonary embolism, not a stroke. Just like with VSDs, the oxygen saturation on the right side of the heart goes up as oxygenated blood from the left side of the heart travels to the right side of the heart. So they'll have increased O2 saturation. Finally, ASDs are associated with fetal alcohol syndrome and Down syndrome. Here's a drawing of an atrial septal defect. As you can see here, there is no septum between the two atria, allowing blood to flow from the left atrium to the right atrium. Again, this occurs because the pressures on the left side of the heart are typically much higher than the right side of the heart, so the blood naturally moves down its pressure gradient. We covered many of the details of a PDA in the fetal and neonatal circulation videos, so I'm not going to go through all of that again. But as a brief review, recall that the ductus arteriosus is a fetal structure that's derived from the left sixth aortic arch and is a fetal vascular connection between the main pulmonary artery and aorta. In utero, patency is maintained by low arterial oxygen and prostaglandin E2 secreted by the placenta. The ductus arteriosus constricts and obliterates after birth. It closes at birth, so the lungs are no longer bypassed as the newborn starts using its lungs normally. Patent ductus arteriosus is defined if it persists up to or beyond 6 weeks after birth. PDA is found to be more prominent in females than males. It's associated with congenital rubella and prematurity. Additionally, studies show that babies born at high altitudes are found to have a higher incidence of PDA than those born at sea level. Similar to the other left to right shunts we've discussed, PDA has a range of clinical manifestations, which largely depends on the size and length of the PDA. Patients with a PDA are generally asymptomatic and are usually diagnosed because of an incidental finding on physical examination later in life. Symptomatic PDAs present with a machine-like murmur, which is a popular phrase that appears on the boards. It results in right and left ventricular hypertrophy because the ventricles have to work extra hard to keep blood flowing. Patients may also present with cyanosis of the lower limbs. This occurs because deoxygenated blood is delivered into the descending aorta, affecting the lower limbs. Finally, patients may have a widened pulse pressure. This can be a bit trickier to understand, so let's pull up a new slide and walk through this together. Here's a photo of a patent ductus arteriosus. You can see within the yellow circle, the connection between the aorta and pulmonary artery is maintained, and blood is flowing from the left side of the heart back to the right side of the heart, like this. Therefore, this is a left to right shunt. Remember, the systolic blood pressure is the top number in a blood pressure measurement, and it refers to the amount of pressure in your arteries when your heart muscles contract. A normal systolic blood pressure is around 120. So the ventricles contract, and blood from the left ventricle goes into the aorta. Diastolic blood pressure is your blood pressure when your heart is between beats and the heart is refilling with blood. This number is usually around 80. So during diastole, the aortic valve closes and the elastic properties of the aorta cause a sustained contraction of blood that propels blood from the aorta to the body. However, if there is a PDA, then the volume of blood in the aorta rapidly decreases because some of it goes to the periphery and some of it goes through the PDA and into the pulmonary artery, like I've shown with the drawing here. Therefore, the diastolic blood pressure drops more than expected. So in this case, let's say it drops to 60. Pulse pressure is the difference between the systolic and diastolic blood pressure. So in a normal patient, we'd get 120 minus 80, which is 40. In our PDA example, the diastolic blood pressure has decreased. So if the systolic pressure is still 120, but now the diastolic pressure is 60, for our pulse pressure, we'd get 120 minus 60, which is 60. In other words, the pulse pressure has widened. All right, that's all for left to right shunts. Let's wrap up this section with a question. A 21-year-old male presents to the emergency department due to left-sided weakness and slurred speech after a long flight. Auscultation of the left sternal border reveals a systolic ejection murmur. An echocardiogram reveals that an area of tissue is missing at the opening of the fossa ovalis. What type of septal defect is most likely present in this individual? Okay, from the question we learned that this patient had left-sided weakness and slurred speech after a long flight, which is highly suggestive of a stroke. The long flight idea is important because it's alluding to the idea that the patient was exposed to hemostasis, which then resulted in a deep venous thrombosis, or DVT. From here, the clot dislodged, traveled to the heart, and normally would have caused a pulmonary embolism. But in this individual, it bypassed the lungs through a defect in the interatrial septum and went to the brain, resulting in a stroke. So hemostasis resulted in a DVT, the clot dislodged and then bypassed the lungs, which then resulted in a stroke. The physical examination of the heart that revealed a systolic ejection murmur along with the echocardiogram confirms that this patient has an interatrial septal defect. We can also be sure that it's not just a patent foraminovale because the echocardiogram revealed that an area of tissue is missing. Remember, in a PFO, the tissue is present. The interatrial septum just hasn't fully closed after birth. Finally, the location of the defect is at the opening of the fossa ovalis, which means that this patient has a secundum atrial septal defect. Recall from this image that a secundum ASD occurs at the foraminovale, which in an adult is known as the fossa ovalis, and we can see that right here. Therefore, because the echo revealed a defect in this location, we can be sure that the patient has a secundum ASD. So again, the answer to the question is a secundum ASD. And with that, we've covered everything you need to know regarding left to right shunts.